Good evening and welcome to A Deadly Silence. I'm your host, Larry Curtis, and it's the goal of all of us associated with our program to bring you current and educational information associated with the drug and alcohol epidemic, not only here in the city of Brockton, but throughout all of our South Shore communities. This evening, we are pleased to have with us from Gosnold, Kevin Rosario. Kevin is the Regional Outreach Representative for Gosnold, formerly Gosnold on Cape Cod, as those of us South Shore guys know it. But I want to, mention that Gosnold was founded in 1972. It is an award-winning, nationally accredited, not-for-profit addiction and mental health treatment provider with programs and services that address addiction at every stage: prevention, early intervention, treatment, and recovery management. Kevin, welcome to A Deadly Silence.
Thanks, Larry. It's good to be here.
So, how did you become involved in the addiction recovery arena? Let's start there. A little bit of your background.
So, my background is basically I'm a person in long-term recovery.
Okay.
And sometimes I disclose that, sometimes I don't, but I can't tell you how I got into the field without bringing that in, because otherwise it would be a little more odd for me. But through my own journey, my trials and tribulations, I found recovery, and I got really passionate about it. And a friend of mine was working in the field, and they were looking for someone that was young and energetic and wanted to be helpful to others in early recovery. And I ended up getting a job at a local treatment center in Brockton, and I did that for a couple of years and learned some things. And I ended up going on to Gosnold, and I got certified as a recovery coach and a family coach and an interventionist. And I just kind of kept moving along into community outreach. And it's been really my personal passion to be a carrier and a messenger of hope. It's not something for everybody, but I feel like the people that are personally attached, have a personal connection, they come out with a different zeal and a different fire. So I bring my own struggles, I bring my own experience, I bring my own hope to my job every day. Like when you sit down with someone and they're in a bad way, and a patient's struggling and they're down and out, or a family is reeling and they don't know what to do, you can look them in the eye and say, I get it.
I've been there.
I've been there.
Yeah.
And it brings a different piece. Mm-hmm. And I have a lot of training, and I have a great clinical team around me, and I learned a lot over the years. But when push comes to shove, usually that emotional, personal attachment puts people at ease a little bit more, so that they'd be more open-minded to like some of the other recommendations and stuff.
And I think we find that's really important when you're dealing with somebody that's dealing with a substance abuse disorder, because there's a tendency for them to buy into what you're saying and communicating, whereas, a lot of times they might just look at it as an educated professional out of healthcare.
Right.
You don't know what I've done. You don't know where I've been.
Right.
And
you meet that across the board with patients and families, because the number one mantra is always, you have no idea what it's like. You don't get it. And that's the patient and that's the family. And sometimes the family suffer in silence, right? Because nobody does understand. And it's not something you talk about at the water cooler at work. It's something that's really uncomfortable to talk about because of the stigma and the lack of education associated with it. So that's why it's so important to have family support groups like Learn to Cope, Al-Anon, Narc-Anon. Gosnold runs 5 of them. We have one in Situate, would be the closest one to this area. But it's a place where families can go and be around other families who know what it's like. And there's studies that show that groups of people with similar backgrounds heal together at a better rate. You see it with cancer survivors, veterans, people in recovery, and families. There's that camaraderie that you just understand more than anyone else understands. And it brings a level of comfort to that person at whatever level they're at,
You touched on something a minute ago, dealing with the stigma of addiction.
Yep.
Having now been a person in long-term recovery, having now been a coach, a mentor, clinician, what has changed over the last several years, or has there been a change in the whole stigma issue of addiction?
That's a great question. I feel like there's a good shift. Stigma still very much exists. It's a barrier to treatment. It's a barrier to people getting hope. It's a barrier to insurance companies paying for adequate care, because there's this conception at a high level nationwide, maybe even worldwide, that this is like a moral thing or a choice thing, or, we paid for you to go to detox for 7 or 10 days. So if you have a regression after that, you chose to do that. That comes from a person that doesn't understand the brain disease of addiction. It comes from a person that doesn't know what it's like for a person to be removed from alcohol or all the other substances, and then they're left with self. Self untreated is the reason many people sought relief in chemicals in the first place. They do something for you. You know, they like the effect produced by it. And like when you remove them from that, they're uncomfortable. You know, and recovery is not about not using drugs or alcohol. Really, recovery is about, okay, now we've taken this substance away from you that's causing a lot of harm, that's creating problems in your family, in your community, whatever. Now we need to help these people, these patients, learn better coping skills, learn how to deal with anxiety, stress, depression, family, loss, grief, PTSD. They come in with different types of trauma, although that's not a prerequisite. There's a lot of people that come from great families that had everything at their disposal, but through experimentation in early grade school, elementary, most likely junior high and high school.
As we've seen today, even prescription medication, given what might be ailing a particular young man or woman. Then.
Right. They say 72% of people that are addicted to heroin now that check into our treatment facility, 72% of them report the first time they tried an opiate was from a friend or a family medicine cabinet, a prescription opiate. It's very rarely do they start with heroin. It's a progressive illness, you know. So the stigma thing in the state of Massachusetts, you got to give, you know, we're in a good place. I give credit where credit's due, and we're doing a lot of good things, and Governor Baker's done good things, and we're trying to get out in front of it and raise awareness about it so that we can get the funding and get the programs and get people the help that they need. But you still see it. You see it less among the people that are involved because we're all at these same things. But if you talk to the average American walking down the road, it's like junkies, this, that. Why do we keep giving them Narcan? They obviously don't want it. And it's like this really nasty negative thing when in reality this person's suffering from a brain disease, you know. And we hold people accountable. You had to drink the first drink. You had to take the first pill. It progressed, and you have accountability for yourself all along that way. But at some point, you crossed the line into addiction, and the chemistry of your brain changed. And your ability to make good decisions and pause and be rational and do things that normal citizens take for granted is inhibited. It doesn't function that same way. And they have a very, lack of impulse control. You know, so that's why it's been deemed a medical disease or a mental health disease. Just look at, you know, obesity or lung cancer, or you can name a lot of other things that, not to say that they're self-inflicted, but the patient may play a part in the procurement or the development of that disease. They made some bad decisions. Now they have this illness.
Obesity, eating wrong.
Right.
Right.
But we don't treat them that way. Right. We say, oh, man, we'll give you the best care. We'll put you in this clinic, and you'll get long-term treatment. And we work with them, and we don't look at it the same way. Like if a diabetic goes into like a, you know, and I'm not a doctor or a clinician or a psychiatrist, so I'm just speaking from my own experience. But like, if you see a diabetic who is in a bad way physically because of their high sucrose levels, they can go into treatment. They can go into a hospital setting. They can be stabilized. They can be given a regimen to successfully manage their diabetes. Diabetes, like addiction, is a chronic illness. It doesn't go away, but it's very manageable. So these people go into treatment, they leave treatment, they diet, they exercise, they walk, they stop watching the sugars that they eat, and they remain in remission.
And they have follow-up treatment.
They have follow-up treatment for a lifetime.
Yeah. Right.
But if the diabetic veers from their treatment plan, much like addiction, symptoms return. Symptoms are craving for sugar. They have a resumption of use, they intake the sugar, all of a sudden sucrose spikes, they can go into shock, they end up back in the hospital, and the doctor doesn't say, "You stupid sugar junkie, you must not be ready. You don't want this. How could you do this?" No, they would say, "Oh, we understand, Mrs. Jones. You fell victim to a craving. How can we help you next time come up with alternative solutions to help you get through that craving?" And we love them up, and we support them, and we restabilize them, and we never put a limit on treatment, and we never like make them feel bad about themselves. We really give them good quality care. And addiction is just like that. You can put someone in treatment for a week, a month, 6 months. They can be stabilized. They can be doing really well. The symptoms have been minimized. They're not obsessing about using. Their behavior has stopped. They're not physically addicted. But if they get away from that treatment plan, whatever it is, it could be church, 12-step integration. It could be medication-assisted treatment. It could be It could be all of those things. Whatever the case is, you help someone find tools to be successful in recovery. And typically what you find with regressions is someone checks in a treatment after having a reoccurrence and they say, I was doing this, this, and that. And they stopped. They stopped going to meetings. They stopped seeing their therapist. They weren't going to IOP anymore. They stopped taking the medication that was helping them with their anxiety and depression. And they got overwhelmed again. And the symptoms of addiction came back and the brain said, just use one. Just have one drink. Just one pill. And they're back in detox. And society says, you chose to do that.
You chose to take the drink. You chose to put the needle in your arm. Whatever. You chose to take the pill.
Correct.
Right.
And if you have any personal experience with addiction, you'll have seen many people that are broken, they're desperate, they're sad, their family is in shambles, legal, physical, medical, everything's in a bad way. And they check in, and I believe if you ask them, and when they say they never want to use again, and I believe they'd pass a lie detector test if you took it in that moment. But when they leave and they don't have the supports that they need, they don't have the treatment plan in place that they need to be successful, after a period of time, they fell victim to it again. And they have a regression. And they left with no desire to use. They never want to use again. And they believe that with all their might. But without good wraparound continuum, without these supports in place to help them be successful, they fall victim to that thought again, that obsession. Or they're just so overwhelmed with feelings. They say the best and worst thing about recovery is feeling feelings. So in early recovery, feeling feelings is really overwhelming. In long-term recovery, it's good to cry. It's good to laugh. Sometimes you got to be sad. You know, we all go through our personal stuff, and sometimes you just got to ride that out too. But like in early recovery, it's so overwhelming, you got to wrap them up with supports. You know, one thing that I think has been really successful with Gosnold, and it's a shame that insurances don't pay for it, we've got to do a lot of like kind of experiential treatments to get better outcomes, to help people be successful and help families, you know, be reassembled. And the recovery management is one of those things. And like a patient can go through our system, you know, detox, 28 days of inpatient, maybe they go to residential at Miller House or Emerson House for a month or two. But the disconnect is when they leave. You can send someone to a $100,000 facility for 3 or 4 months and they do well. You manage their care. You tell them when to wake up. You make breakfast, lunch, and dinner. You drive them to meetings. You do their laundry. It's actually, I could use one of those right now. You know? But what happens, yeah. But the disconnect is when they leave. Someday in real life, they got to go home. And they don't have the ability or the skill yet to really follow through with a treatment plan.
And nor does the family or loved ones have that knowledge or skill or ability to do that.
They have no idea.
Yeah.
And the family wants to believe that this period of treatment has solved the problem. They want their kid back. They want their husband back. They want to go back to normal life. The family is just as important to work on them and get them to buy into the chronic disease model, that this is something that's manageable, but we got to keep an eye on it for a lifetime. They're not done. They didn't graduate treatment. The show goes on. And someone like a recovery manager or recovery coaches, you're seeing them working in the hospital setting and in different settings. Our particular program, we call them 5 days a week. We don't wait for them to call us. We call them 5 days a week. If they don't answer the phone for like a day, at the end of the day, we're calling the mom, we're calling the brother, we're calling someone. We get a list of all their closest supports, and we call them. And we do early interventions before there's a resumption of use. Hey, you're not answering the phone. You're not going to meetings. I heard you missed your counseling appointment. We get a release for all their providers, and we meet them twice a week face-to-face and help them treatment plan. What are your goals, and how can we help you get there? And then we do monthly family meetings, and we bring the family in, and we tell them this is what they're doing well, this is what they need to work on, and then we coach the family. We say, what are you doing for you? Little Billy's got a sponsor, a home group. He joined the gym. He's in a recovery house. He's got a therapist. He's on Vivitrol. Little Billy's doing pretty good. He's wrapped up, and mom's still at home waiting for the phone to ring. So we encourage the families, hey, look, we know that this may not be your fault, but little Billy's recovering from an addiction, and you need to recover from little Billy. How can we help you? And if you see the family buy into their own recovery and they go to family support groups and maybe they see a therapist and they go to the gym and they get back to sleeping regular and just getting healthy again, the patient actually has a much higher success rate because the whole dynamic is healing together. And that's one thing that's been really cool and I'm really proud of about Gosnold is the family integration, how you look at the whole system and you don't look at a period, a certain amount of time, but you look at the lifetime treatment of the patient and the family to help them be successful.
Now, it's fascinating when you talk about all the spectrums of recovery that you talk about, detoxing, short-term or even long-term inpatient, then intensive outpatient programs and so forth,
Yep.
and then the support network that you would get, be in sober houses or whatever. How is that all paid for? I mean, obviously it's one of the challenges that, families have to deal with. We hear horror stories of families spending their life savings, sending their son or daughter off to a treatment facility,
Right.
only, as you mentioned, 6 months later,
Right.
without the backing, they're back addicted again.
Right.
So how does that come into play?
It's a challenge. It's a challenge, and the reality is that insurances make it really difficult for us, and they make it difficult for families. And the state is good, and there's DPH funding. So to answer your question, it comes from a lot of different areas. So insurance will pay for some things. So like we're in network with many insurance providers, and we take Medicaid. So just about all insurances will pay for detox with us, but they deem that medical necessity only 4 to 6 days. Mm-hmm. And then if the insurance follows the mass mandate, they'll pay for 14 days of rehab, right? So like for us particularly, we have the detox, the 28-day inpatient, and then once you go to residential, it becomes self-pay. We do have some DPH funding, but the men's house is only 23 beds. So there's a ratio that you have to self-sustain. So the reality is like a lot of people end up paying out of pocket for really good care. Now, the good thing is we've been really shifting some attention to upgrade and improve our outpatient services because insurance will pay for outpatient. So we have, individual counseling. We have SOAP, which is a structured outpatient program for people with substance use disorder. And then IOP is dual diagnosed. So there's a mental health component. But just recently, we opened a PHP, which is a partial hospitalization in Centerville, which is a little town in Hyannis. And that's 5 days a week, 6 hours a day, intense groups. And that's a step down from an inpatient stay or someone that doesn't need inpatient. You don't have to go to detox to enter another level of care with us. You can go to that day program, and that could maybe help you get back on your feet. But there are other ways. So like if you go into the state system now, there's a lot of programs that have more beds for mass health and DPH funding. But the problem is, unfortunately, things are so bad here right now that the supply doesn't meet the demand.
Can't meet the demand, right.
So in theory, I'm a product of long-term treatment. That's why I love Gosnold, because we have all these systems in place. I'm a product of going to detox, going to a halfway house, having a therapist, having a psychiatrist, going to the gym 4 days a week, going to a meeting every day, getting a sponsor, working the 12 steps, eating healthy. So it's like this whole mind, body, spirit model. It's not just clinical. It's not just 12-step. It's not just physical in the gym. But I am a product of experiencing all of those things. And some had a bigger impact than others, but like I was in a safe place for 10 months before I moved back home. And that's what it took for me. 3 days, 10 days.
And everyone's different in
Right.
that road to recovery as to, sustaining that long-term recovery road.
Some people don't need to go that long. Mm-hmm. Some people, and ideally you catch them earlier on, and they can be, stabilized and given some supports and be successful. Other people need an extended period of time because of the way the brain works. You remove the substance, but then there's this anxiety, there's this depression, there's this racing mind that takes months. They say post-acute withdrawal, left untreated, can go up to a year. Post-acute withdrawal is like lack of motivation, then like mania. Irregular sleep pattern, irregular appetite. And these things look like severe mental health. Sometimes they are, sometimes they're not. Sometimes it's just what it looks like after an acute withdrawal. Mm-hmm. You have this irregular emotional, mental, and physical thing that it takes time for that to level out. Regardless of what kind of treatment model someone engages in or enters in, I feel like the key is to know and accept on a deep level, all right, I have this thing, and I'm going to have to keep an eye on it for the rest of my life, whatever that looks like to you. And we meet people where they're at. We don't put anybody in a box. At Gosnold, it's not like, do it this way, this is the way we do it. We sit with them. We ask them questions. Some people come in and they're homeless 22-year-olds. Some people come in and they're CEO 60-year-olds. They have different responsibilities. They have different things they have to take care of. So you meet them where they're at. You come up with a game plan and a treatment plan that best suits that patient. Each patient can get an individualized treatment plan, and you work with them. And as far as our continuing care goes, we work with families. We try to build insurance for as much as we can, and when it comes to that self-pay portion, we'll work with a family and try to make it comfortable because we want to keep them. We want to keep them as long as possible. We don't want to, someone's care shouldn't be based on when insurance stops paying. It makes me really sad. that's like sometimes the case. You know, if 47,000 people died last year of Ebola, we'd have the National Guard around this country. We'd have billions of dollars in funding, and we would solve the problem. We would address it. But we don't see that. 47,000 people died last year of an opioid overdose.
Opioid overdose.
Yep, over 1,500 just in Massachusetts.
1,531 in 2015, exactly.
So where's the funding? You know, that's my thing. You know, our hands are tied.
It goes back to the stigma that you had mentioned, whether it be, you know, personal, family, political, a lot of political, you know, stigma there, you know. And, you know, you'd mentioned earlier that, you know, we're fortunate to be in Massachusetts because as a state, we're kind of leading the country.
We're doing a great job
in addiction and recovery. You know, putting the resources, acknowledging the fact. It goes back to 2013 when Governor Deval Patrick declared it a public health crisis. All of a sudden, that kind of just opened the door of awareness, you know, and education out there, for sure. Within Gosnold itself, what should a family expect if they have a loved one that's dealing with a substance abuse disorder and they get an opportunity to enroll in the program?
I would say you need to know that like the fight is not over if you got a bed in detox. That's really just the beginning. And then right away, you're kind of against the clock with all these regulations and these insurances. You know, like they're only going to pay for 4 to 7 days of detox, maybe 14. And then it's our job, if the patient's willing and motivated, to help them get to the next level of care. If it's not with us, it's somewhere else.
Let's talk about that piece of it, though, because you hear a lot about the fact that, you know, nobody's going to be able to help the person dealing with substance abuse disorder if they themselves don't want to be helped. How does that
So my view of that has changed. I know we talked the other day about it, and I used to be of that old mentality. They're not ready. They haven't hit bottom. That rah-rah, you know, old-timers mentality. And my experience with Gosnold is I'd seen patients come in 22 years old with zero desire to stop, and the family was able to do an intervention, cut off resources, make it uncomfortable, almost force the hand into treatment, and then with a recovery manager, a clinician, with a whole support team, the family around it, and really educating and empowering the family, we were able to push this patient along in treatment. And I think of one that comes to mind. I won't say his name, but this guy was kicking and screaming. He wanted nothing to do with it. I picked him up to go to an interview, and the kid's like got skater pants on. He's all banged up. And I'm like, buddy, what are you doing? Like, he's like, I want to be myself. And I'm like, I understand that. But in the real world, you got to suit up to show up. I literally took my shirt and tie and my pants off, dressed this kid in my clothes. He went in the interview, and he got the job. And over a period of time, this young, like stubborn, resistant young man bought into it. And I was on the phone with him today. He's got over 2 years in recovery. He's a student at UMass Dartmouth. He works for us part-time. He has another part-time job moving. He's really engaged in recovery. He still goes to meetings. He's still giving back. And like, this kid's a miracle. And he is someone that if by what people say, wait till they're ready. This kid was not ready. He was not happy about it. He had an open case, so we had leverage against him. We kind of forced him along his path, but you never know when someone's going to hear something. And he started to feel better, and he started to reap the benefits of being engaged in recovery, and then he shifted from, I'm kind of being forced to do it, to like, this kind of ain't that bad, to I'm in it. I'm a guy in recovery now, and he's doing well, just for today. You know, it's one day at a time. Like, I still do certain things. I still go to the gym. I meditate. I do certain things. I'm still involved in 12 steps. I help other people off the clock. I need to do that to maintain my recovery. He does certain things that help him maintain his recovery. I know another guy doesn't go to meetings. He's a volunteer at a youth basketball league, and that's how he finds fulfillment and gives back to these young. He's found purpose. He's really happy. He's doing well. So whatever it is a person finds to come back from addiction and starts to like heal, they got to stay with it. And it might morph and it might change, but that's the biggest message I like to tell people is like, you gotta stay on it. But recovery is possible. People do get well. If they're still breathing, there's hope. That's my thing. We don't have to ever give up on them. Just keep trying, keep pushing, and people do get well.
One of the difficult things that the loved ones of a person dealing with substance abuse disorder are confronted with is that fine line of helping versus enabling.
Right.
You know, what would you say on that?
It's just a matter of, look what happened.
Oh, you fell
Here's
off.
my guy. So we're still live. We don't care. We'll make it happen.
All right, we can fix that.
It's because I get a little crazy and animated. I'm Portuguese. I speak with my arms, you know what I mean? So just before I forget, too, I got to give Brockton a plug. We're in Brockton. Like, we have an outpatient office right here in Brockton, 111 Torrey Street. And we're actually expanding. We're looking at a site. I believe we secured the site in Stoughton. It's right on the Stoughton line. And we're going to be offering that PHP, partial hospitalization, IOP, and SOAP in Stoughton as well to be able to better serve this area and this community. The phone number is 508-584-5190. I was with them, and they said, hey, don't forget about us. So I got to do that for them.
We're going to come back and have a second show, and we're going to talk about that a little more in depth. So we'll get that plug in as well.
Okay. So going back to
the enabling versus the fine line of enabling versus helping.
So I don't even like to use the word enabling because it makes the parents feel bad or it makes the loved one feel bad. And it's important to know that this thing affects friends too. Sometimes the family's long gone and it's the friend or the spouse that's in there, hanging in there. And enabling is like, you don't enable. It's like almost blaming them when we know they're just trying to protect them. And they're scared and they love them and they're doing the best they can do. So we try to just give them some education and direction about how to best love them, how to best protect them, and how sometimes allowing things to happen under your own roof is actually, in fact, not helping them. So at the end of the day, the family has to be able to live with whatever decision that they make, right? So we never tell them what to do, but we give them ideas. We say, if you're in a position where they're living with you, you're paying their rent, you're paying the cell phone, you're paying the car, if you have that much power, then you have more power to force a change than you think. What's more difficult is the person that is self-sufficient because they'll just cut everybody else off. So you got to educate the family in a different way. But oftentimes, especially the under 30s, the family's supporting them 100%. So they think they can't make them do anything, but in fact, maybe you can't make them do anything, but you can make it uncomfortable for them. So the language I like to use, and I learned it from someone, I didn't make it up, I've been around a lot of awesome people, is we'll support you in your recovery, but we will not support you in your addiction. And what that means is if you're willing to get help, if you're willing to try, whatever that looks like, we got your back 100%. Whether it's emotional, financial, whatever it is, we'll support you. But if you don't want help and you want to continue to drink or use or suffer with mental health, people die every day from untreated mental health. It doesn't have to be just substance abuse. Gosnold is a standalone mental health provider, and we see a lot of people in the same stigma. They have bipolar, they have schizophrenia, they have something that is not being managed well because they don't want to be honest about that. And we tell the family, listen, support them if they're willing to get help. If they're not willing, then you have a choice. You don't have to pay the cell phone. You don't have to let them live with you. And what's going to happen is that might be something that helps encourage them to go. But the parents operate from love and from fear, two very powerful forces. And the love wants to keep them and protect them, and the fear is afraid if I kick them out, they'll die. And you can never tell a parent what decision to make, but you can say, listen, if you're paying for the car that's getting them shoplifting to buying drugs, you're paying for the cell phone that's full of drug dealers' numbers, they're living with you, they're shooting heroin in your house. Mm-hmm. You maybe not be able to stop them, but you can make it a lot more difficult for them. Why would you ever leave? Why would I ever leave my mother's home if they're going to cook, clean, pay my rent, pay my car, pay my cell phone? There's jewelry I can steal. It's like a haven for someone in active addiction. You don't have to do anything, but you might want to not engage in any kind of activity or behavior that's making it easier for them to keep using. And if they leave and they're not going to accept help, then you hope that they don't die because the pain will bring them in sooner or later.
Well, Kevin, believe it or not, we're at the end of our show. 28 minutes goes by really
Yes,
fast here. This has been fascinating. I want to have you back for another show, and I want to thank you on behalf of Deadly Silence. Thank you for taking the time coming up and sharing with us, what's happening out there in addiction recovery. On behalf of all of us here at Deadly Silence, we'll see you again at the next episode.